Good afternoon, everyone. It's great to be here. My name is Ellen Barry. I'm a reporter covering mental health for the New York Times, and I am your moderator for today's discussion, Mental Health and the Ripple Effect, Navigating Comorbidities. This session of the forum will focus on the complex relationship between mental health conditions and the development of secondary health issues. I'm delighted to introduce our panelists for today's discussion. We have Dr. Arthur Evans, the Chief Executive Officer of the American Psychological Association, the leading scientific and professional organization representing psychology in the United States. Before joining APA in March 2017, Dr. Evans spent 12 years as Commissioner of Philadelphia's Department of Behavioral Health and Intellectual Disability Services. Dr. Evans is also a member of the Research America Board of Directors. Dr. Joshua Gordon, a psychiatrist and neuroscientist, currently serves as the chair of the Department of Psychiatry at Columbia University's College of Physicians and Surgeons. He also serves as executive director of the New York State Psychiatric Institute and psychiatrist in chief at New York Presbyterian Hospital. Prior to this appointment, Dr. Gordon served an 8-year tenure as director of the National Institute of Mental Health, the lead federal agency for research on mental illnesses, where he was at the forefront of mental health research and policy. Dr. Charles Nguyen is medical director and founder of the Lorphen Medical Weight Loss Clinic. His extensive research, clinical experience, teaching, and training in psychiatry offer a unique perspective to help his patients lose weight. He is the author of the Thinsulin Program, the breakthrough solution to help you lose weight and stay thin, a book that was voted by the LA Times as one of the top diet books in 2016. And finally, we're joined by Dr. Maria Ryan. Dr. Ryan is Executive Vice President and Chief Clinical Officer at Colgate-Palmolive, where she provides oversight and leadership to dental and dermal clinical organizations, knowledge management, and scientific communications teams. Dr. Ryan previously served as professor and chair of the Department of Oral Biology and Pathology at Stony Brook, where she was actively involved in teaching, clinical practice, and periodontology and research. Thank you all for being here today. We've come together to discuss a unique aspect of mental health and healthcare, the development and management of secondary health conditions or comorbidities that present in patients experiencing mental illness. So I'd like to begin by defining our terms. Dr. Gordon, how would you define comorbidity in the context of mental health? Is it merely that two conditions are present at the same time, or does it imply a causal relationship between them?
I think operationally, it's just that the two coexist in the same individual. And when you get down to causality, there are many different forms that could take. One process could be causing both the two conditions, or one process could be contributing to both, or one of the conditions could lead to the other. And we'll probably talk about all those different potentials throughout today's talk. But when we talk about comorbidities, fundamentally, we're talking about the phenomenon that we can observe two different conditions in the same individual at the same time. And it's up to the clinician, up to the investigator, if they're doing research, to figure out what is the relationship between those two or more.
And could comorbidity be related to a treatment that causes a secondary health condition?
Absolutely. And if we're talking, for example, about obesity or diabetes, we know that some of the medications we use in psychiatry to treat, for example, psychosis will cause weight gain and raise the risk for diabetes. So there is a comorbidity that is causally related, not to the first illness per se, but to the treatment offered for that illness.
Dr. Ryan, please tell me how oral health generally influences mental health and the other way around, and what kinds of dental conditions most impact a person's well-being.
Thanks, Ellen. It is really a two-way street. It goes back and forth. And actually, Dr. Gordon described a lot of the things I'll talk about quite well, in that we find, for example, what makes someone more prone to getting dental disease? Smoking and drinking. Yet many people who have mental health issues sometimes turn to smoking and drinking. But let's start on the first side, oral health's influence on mental health. We're a global company. We did a study recently in 12 countries, and we looked at the links between oral health and mental well-being, where we found that tooth pain leads to worry, anxiety, and sadness, particularly in children and even in their parents. Dr. Natalia Chalmers, who's our first chief dental officer in the United States, just gave a talk at another meeting I'm at, and she talked about the most common reason that children miss school, and it is oral pain and discomfort. And when we think about this can lead to isolation. It can hinder their education and their social development. And there was a recent study that came out of the University of Birmingham in the UK that finds that people with periodontal disease or gum disease and tooth issues can have an increased risk for suffering from depression and anxiety by nearly 40%. And also, poor oral health can really impact a person's quality of life and lead to more frequent episodes of pain and discomfort, which really affects their ability to eat and speak. And this can lead to social isolation and low self-esteem, which can really exacerbate mental health issues. And there is also a link between periodontal disease and the formation of amyloid plaques, because periodontal disease is the most common chronic inflammatory condition in the world. And it's a disease of infection and inflammation. And so there has been that connection that has been found. And also prolonged periodontal disease and tooth loss has been associated with a risk for cognitive decline and dementia. But if you look on the other side, mental health can influence oral health, and people with mental health conditions, particularly those experiencing serious symptoms of mental illness, they have difficulty in general maintaining effective hygiene routines, including dental care, and they may have difficulty accessing the necessary dental treatment that they need. And to compound this, we all have heard about people who are anxious about going to the dentist, who have phobias about going to the dentist. So it makes things even worse. And people with severe mental illness are 2.7 times more likely to lose all of their teeth and become edentulous than the general population, as published in the Canadian Journal of Psychiatry. And conditions like obsessive compulsive disorder and bipolar disease can actually lead people to damage their teeth, brush more vigorously. Bulimia will cause dental erosion of the teeth. And stress can cause bruxism and grinding. And there are a number of medications, which actually Dr. Chalmers just brought up, that people often take as antidepressants or anti-anxiety drugs that can cause dry mouth. And when your mouth is dry, it increases your risk for developing cavities and periodontal disease. So, mental health certainly can also impact your oral health.
I'm really struck, Dr. Ryan, by that correlation you mentioned. I think 40% correlation between depression and gum disease. Is that right?
Yes,
And I wonder,
yes.
how can you unpack the causality there if it exists?
Well, for the reasons that I just said, if your mouth is drier and you're taking medications, one of the common things for periodontal disease is excessive force on the teeth. So if someone is grinding, they're anxious, their mouth is dry, all of those things we know increase your risk for developing periodontal disease. So we know that once you have periodontal disease, many people, when they lose their teeth and they feel like they can't get a job and they can't be with people. And, you know, we don't even talk about other things like halitosis. I remember having a patient saying, everyone moves away from me. Why are they moving away from me? And he was very upset about this. And fortunately, I worked at a major medical center, and I worked together with my colleagues across the street to really help this patient to manage his anxieties. But some of it really was related to the oral health conditions that he had. And together we were able to manage the patient.
Dr. Nguyen, let's talk a little bit about obesity. Tell me, how do you see mental health conditions contributing to obesity, or the other way around?
Thanks, Ellen. Yes, people who are obese tend to be more depressed, and people who are depressed also tend to be more obese. In fact, those with severe obesity are 5 times more likely to be depressed this past year than someone who has a normal weight. So there's definitely an associations that we see, not just with depressions, and also anxiety. Well, we don't have to, if we really put ourselves in their shoes, if you're sad and depressed, you don't have the motivations to get out of the house. That's definitely going to increase to the sedentary lifestyle. Likewise, if you're anxious, if everything that you do causes a lot of anxiety, the likelihood of you going out of the house is going to be less. So you're less likely to be more active. So that definitely can increase to a sedentary lifestyle. But I don't think it's just the lifestyle by itself. A lot of times, those with severe mental illness, they don't have the social economic means. So the choices of food that they have access to can also be a contributing factor to the risk for obesity. And like Dr. Gordon mentioned earlier, a lot of the medications that we use to treat not just schizophrenia, but also bipolar disorder and depressions may increase the risk for weight gain and other metabolic risks as well.
And I wonder, how much does that weight gain as a result of antipsychotic use contribute to excess mortality in people with these illnesses?
As there's a lot of studies that have looked at that, there's no doubt that the increased risk for metabolic syndrome can be attributed to the risk of having weight gain and obesity. But the direct correlations, that still has been debated. Will antipsychotics directly cause that? Maybe indirectly or maybe directly, but the data has not really been shown to be one way or the other.
Dr. Ryan, let's talk a little bit about interventions. What seems promising? What are you looking at?
Yeah, I mean, I think in general, health literacy is very, very important. And particularly when we talk about mental disorders, I mean, we need to remove the stigma from that. Even in talking to patients over the years, sometimes they're reluctant to talk about it with me as a dentist. So that's very important. When it comes to oral health, many people are completely unaware about the connections between their oral health to their overall health and well-being. And we actually developed a program, it's a little quiz, to try and get people to understand more about their oral health. KnowYourOQ.com. It's Know Your Oral Health Quotient, like you know your IQ or your EQ, as a public service. And what the interesting thing about it is, we put one of the 10 questions was, is your oral health connected to your mental health and well-being? And most people in dentistry, we don't talk about it. 85% of the people who answered that question said yes. So people themselves really feel that there is this connection between their oral health and their mental health and well-being. And I think this kind of education is important not only for consumers, for patients, but for other practitioners, because we need to work together to best manage our patients. And I don't know how many psychiatrists are talking to their patients about their dental health and the connections between mental and dental health. But for oral diseases, most of our diseases that we treat are preventable by brushing twice a day for 2 minutes, flossing once a day, using mouthwashes, and connected technologies can help people to have better habits and with self-care. And we actually did work with a colleague of mine who was a psychiatrist, and we were talking about how do you get people to engage with self-care? And even before someone might take a shower, their first steps of feeling better is brushing their teeth. So it was very interesting that, you know, that could actually help people with mental health issues to begin to get out, to begin to take care of themselves, to begin to move on. But when you think about patients with neurodegenerative disorders, they should have comprehensive oral care, including preventive dental visits. And those people who are missing their teeth, they need to have them replaced with either implants or dentures to really improve on their nutrition and their quality of life, which reduces the risk for physical and mental decline in these patients. And those with eating disorders like bulimia or who are bruxing, they need extra fluoride treatments to maintain the integrity of their teeth, and treatments like mouth guards that protect the teeth from the bruxing that they're doing. And as you lose tooth structure, your teeth become more sensitive, so you need desensitizing agents. And then finally, for those with dry mouth must be addressed. They need to hydrate more. They need to use oral moisturizers, which you can buy over the counter in the store, mouth rinses, chew gum, which stimulates the salivary glands. So there are things that they can do. And then, of course, we try, if that doesn't work well, to work with our medical colleagues to see if maybe we can use another medication, which sometimes they can and sometimes they can't. So we learn to work around it.
Dr. Nguyen, let's have the same conversation about interventions with obesity. What's working? What are you interested in?
Well, I think to be most effective in obesity treatment, we need to take a biological, psychological, and behavioral approach to weight management. Meaning biologically, there is chemical imbalance that we need to address. Perhaps maybe giving a medications to help suppress their appetite, reduce that hunger, giving medications to increase the satiety so they don't feel hungry all the time, or even addressing some of the insulin level that's needed to kind of help maintain that. But psychologically, it's really important to address up here. For example, if we tell a negative person, hey, you want to be happy, just be positive, would that work? No. So why would it work if we tell someone, if you want to lose weight, just eat less and exercise more? It's no different than telling a depressed person, just get over it. Unless we use some form of psychotherapy, which I really promote using CBT, cognitive behavioral therapy, to help change your mind, to help change your way of thinking, then we can change their behavior. But lastly, we need to look at the behavior aspect, giving them tools how to break bad habits and really form new ones. So that way they have a much better chance of having long-term success.
I can see that there would be another level of complexity if the weight gain is associated with your medication. And I guess I wonder, in those cases, if someone is put on an antipsychotic that leads to weight gain, what's the best way? I can understand how that might lead them to discontinue, and I think it often does. What's the best way of leveling with the person and getting them ready for that?
Yes. That's a great questions that we have to encounter every day in our discussions with our patients. But at the end of the day, it's weighing the risk and benefits. There are medications that have less weight gain potential compared to others. But if that works, then that's great. But for some who cannot tolerate, or those other medications that doesn't cause as much weight gain doesn't work, then we have to use those who are more likely to cause weight gain. And if that's the case, then I think using simple nutritional behavioral modifications can really help. Maybe addressing soda, juice, Gatorade, and some of the higher caloric snacks. If we can minimize a lot of that, then maybe we can minimize some of that weight gain that can be associated with the medications.
Dr. Evans, let's talk a little bit about prevention, how preventive efforts should be structured, and where you see the most hope.
Sure. Well, a couple of things. One is that, as my colleagues have talked about, comorbidities between mental health and physical health are fairly high. And there are comorbidities within mental health and within behavioral health. So people who have, for example, a substance use condition will also often have a mental health condition. They may be depressed, or they may have an anxiety disorder. And so it really creates a lot of complexity in terms of the people who are out there who need help and intervention. So when it comes to thinking about prevention, I think there are two big pathways that we should think about. On the one hand, there are some really good evidence-based treatment programs that can help either prevent or to intervene much earlier. For example, early psychosis programs are very effective. First time a person is having a psychotic break, that they, if you can intervene much earlier, you can really change the trajectory of their condition. So those programs are really important, and we need to continue to fund those kinds of programs. For children, there are environmental interventions in schools, for example, if you can reduce bullying, if you can create programs that, or school systems or school environments that promote resilience, that is a very effective way of reducing childhood mental health challenges. On the other hand, there are we should be also looking at not just programs, but looking at public health strategies that help reduce the likelihood that people are going to develop mental health challenges to begin with, or substance use challenges. So for example, we know that there's a high correlation between people who are exposed to trauma and then people who go on to develop all kinds of mental health conditions. It could be substance use, it could be depression, it could be anxiety disorders. So if we want to get a handle
I think I lost the last part of your comment.
Me too. I think Dr. Evans is frozen.
I think so.
comorbidities, one of the ways to do that is to have effective public health strategies. Hear me?
Yeah, now we can.
Can you hear me?
Yeah, we lost you for a minute.
Oh, okay. I'm sorry. I had bad internet here. What I was saying was that in terms of public health strategies, another strategy is to reduce the impact that trauma has, because we know that trauma leads to not only singular mental health conditions, but often co-occurring mental health conditions. So, for example, sending people into communities in the aftermath of a trauma to do psychological first aid is a good public health strategy for reducing the likelihood of people developing co-occurring conditions. Then there's one other strategy that I think is very important, and that is integrated care. Some of the best hospitals, especially children's hospitals, that address this are those that have integrated mental health professionals, psychologists, onto all of their units. So there are hospitals, for example, children's hospitals, that have a psychologist on every med-surg unit in the hospital. So if a child has cancer, childhood cancer, if a child has other kinds of conditions, they are getting treatment for their mental health challenges as well as their physical health challenges. And we know from a lot of research that when people have chronic health conditions, they are also much more likely to have a mental health challenge, depression, other kinds of conditions. And so I think by having these sort of three types of strategies, programs for people who have co-occurring conditions, making sure that we have mental health interventions at the places where people are receiving their medical care, and then stepping back and taking a public health approach to reducing those risk factors in the community, we have a really good shot at reducing the kind of comorbidities that we've been talking about here.
So we have a couple of questions from members of the audience, which I'll just throw out there to see if anyone has thoughts. The first is whether anyone in the panel can touch on drug-on-drug interactions as they're related to mental health risks. Any thoughts on that?
Well, there are plenty of known drug interactions in psychiatry. Most of them involve raising the risk of toxic effects of a given drug, or changing the dose at which a drug should be administered, or decreasing the efficacy of one drug by treating with another. But certainly where drugs raise the risk of a comorbidity, such as obesity, for example. You combine two drugs that raise your risk for obesity, you are more likely to have obesity or can see more severe diversity in some of those cases. So I would say that there are certainly drug-on-drug interactions that can impact risks for comorbidities. I'm not sure what is meant by related to mental health risks. Certainly, there are drugs one takes for physical conditions that can raise your risk for mental health conditions such as depression. And I would imagine, and we know, sorry, that there are drug-drug interaction risks that can raise your risk for, combined can raise your risk for some of those conditions as well.
Dr. Ryan, we have this question. Are you aware of oral health programs that are integrated with mental health or physical health programs that are doing good research or looking for researchers?
Yeah, well, there are in some very large health centers, right, where we work side by side with our medical colleagues. But, I think one of the things we need to continue to do is to fund institutes like the National Institute of Dental and Craniofacial Research within the NIH, which has really helped to uncover a wealth of data regarding the links between dental and mental health. And so we need to continue to do that work, which I think otherwise may not be done unless we have advocates for that kind of research. And so there are programs, as I mentioned, in Birmingham, in Canada. There are programs in the US. There are many people who are studying these connections between dental and mental health. And so I would advise the person, if they want to get into doing research in that area, to get onto the NIDCR website and to look at who the investigators are who are doing the work in those areas.
Another member of the audience asks how you can see pharmacists playing a role in mental health care. Anyone have thoughts on that?
Yeah, I can speak to that. One of the things that has happened in the mental health world the last probably 20 years, almost 30 years, is a real focus on what's called recovery-oriented care. And simply means that our field has moved away from treating illness to really thinking about how do we help people have the kind of life that they want to have, particularly when we're talking about people who have serious mental illnesses. And by the way, if you do have a serious mental illness, you have a 25% likelihood of also having a substance use condition, as we're talking about comorbidities. But as our field has had greater emphasis on how do you have a life, it's not just about am I asymptomatic, it's do I have relationships in the community, do I have a job, am I able to go back to school, can I do those kinds of things. I think pharmacists can be very helpful in helping to identify medications, for example, that might have additional weight gain or have other side effects that get in the way of this kind of social development and social skills that people may be trying to develop develop as they are in their recovery process. So I think anything that helps provide people with education that not only helps them to manage their symptoms, but also helps them to address those things that may be getting in the way of the other areas and aspects of their lives can be very helpful.
Here's an interesting question from the audience, which is how do our newer weight loss medications interact with this whole discussion we've been having about mental health?
The GLP-1 inhibitors, probably.
Yes, sorry. That's I assume that's what the questioner was asking about. Is there a potential to use these medications to counteract some of the comorbidity and particularly obesity in severely mentally ill populations?
I can share this with you, and maybe Dr. Gordon can also. I'd love to hear his thoughts as well too. But I would caution just to use the GLP-1 agonists just for the sake of weight loss if they are not overweight or obese, not meeting the criteria. But at the same time, if they already, because a lot of times severe and mental illness, they already have obesity. And if they have that and it's tough for them to really control that, then definitely I see a big role in the GLP-1 agonist. And I prescribe a lot of that as well too, to help my patients with their obesity, as well as for their diabetes.
And I'm curious what you've seen. What is the outcome when you've done that?
I find that it would only be effective if it is done with nutritional educations, with the proper food choices and understanding of that. Too often, patients say, "Hey, this is a magic bullet, right? I can take this and eat whatever I want to lose weight," and that's not always the case. In fact, it's the other way around. But if they combine it with proper nutritional educations and learning what to avoid to eat and eating more of food that that are green, that are vegetables or protein, then they're more likely to have the success that they find with the GLP-1 agonist.
Dr. Nguyen, if I might ask, are you aware of studies showing the efficacy of the GLP-1 antagonist, specifically in individuals with weight gain in the context of antipsychotic use?
I think they're beginning to do some of them, but it's not completely, those are smaller studies. The bigger studies are with metformin, but I think the larger studies will be coming out very soon, and I'm anxiously awaiting the results of it.
Yeah, I agree with you. I think it's important that we understand in a rigorous way how these medications can be beneficial. But I'm glad to know that you've had experience working them in the context of additional care, including nutritional services and psychotherapy, that they may be efficacious.
Yes.
Dr. Gordon, I wonder if you can just talk about some of the issues that have come up in this discussion, and particularly how researchers can study these areas with full sort of ethical consideration for the vulnerable populations that they're looking at.
Well, I think the question that I had for Dr. Nguyen indicates that we have what we in the field call equipoise. That is, we don't really know whether these medications can be effective in the context of antipsychotic use. We don't always, we can't just assume that they will. And so we need to carry out studies that are carefully designed to determine the answer to that. We do have evidence-based approaches, some of them ones that Dr. Nguyen uses in his practice, that can be beneficial for individuals with obesity in the context of antipsychotic use. Family supports as well, nutritional navigators. There are a number of evidence-based approaches that have been shown to research to help. So one ethical way would be to study, as Dr. Nguyen suggested, the use of medications in addition to these evidence-based approaches to see if they add to the benefit. And my guess is that they very well might, but we don't know until we actually try the experiment and do it carefully and rigorously.
Could I say something about research? I'm glad we're talking about research, because I think this is an area where we could use a lot of improvement in terms of how we approach studies. We've set up clinical trials as the gold standard. The problem with that is that it really masks the complexity that clinicians face on an everyday basis. To get a good study, one of the things you have to do is you have to control for a lot of variables. And often that means excluding people who have co-occurring mental health conditions and substance use conditions or other kinds of health conditions. And that's just not the reality of what the typical clinician faces. And so we have studies that can't generalize to real world examples or to real world situations, because they were done to rightly figure out what say that, but in order to say that, you have to exclude a lot of people who are the typical people that we see. And so I think we have to have both. We have to have good, rigorous clinical trials, but we have to have studies that really allow us to look at real world people and see what has the most effectiveness. And so I think that kind of shift, or at least expansion of the way we look at research, is really going to be necessary if we're going to develop the evidence-based interventions that we need.
I guess I have a question to that. In your field, how many practice-based research networks are there? Is that common? Because in some fields, it is what we do beyond the traditional RCTs that are run.
I think there are a number of such networks.
It is not common enough. It's great. I didn't know. Go ahead, Josh.
No, good. I think you're right, Arthur. So that's the second half of my sentence. There are a number of such networks or a number of such endeavors. In fact, some of our best evidence for treating obesity in serious mental illness comes from a practice-based, a community-based approach. But Arthur is 100% correct that there are not enough of these, and we need more.
Yeah, so the reason I bring it up is within NIDCR, they actually fund these larger practice-based research networks to, complement many of the other things that we're talking about here as the randomized controlled trials, et cetera. So
if I may add one more thing to what Dr. Evans and Dr. Gordon is saying, I think too often with research and clinical practice and weight gain management, they separate the nutritional aspect from the medications. And I think you need to have a program that combines both of them. And the last thing that's very important too, not a lot of research are combining the psychological, the use of CBT or the underlying reasons, right? Along with the medications and the behavior. I think if we do that, we have a much better chance of really combating the obesity epidemic that we're seeing right now.
I wonder if you can see a time maybe in the future where our treatments for psychosis will not cause so much weight gain.
There are medications that are hopefully coming out at the end of this month that doesn't work through the traditional dopaminergic system that we have. And there's reasons that there's not going to be a lot of weight gain that comes out as a result of this. So there's going to be a lot of hope in the near future for sure.
Well, we're closing in on the end of this panel, so I'd like to ask all of our panelists for their closing thoughts on this important subject. What do you think is most important for members of our audience to take away from this discussion? Dr. Evans, I'll start with you.
Okay. Well, I think there are a lot of great points. I love the conversation we've had today. I think when this last piece of the conversation where we're talking about weight gain and having and psychotropic medications, our field really hasn't paid attention to. We've dealt with people in sort of silos, and we haven't looked at people holistically. And I think this issue really points to one of the big changes we have to make. We have to look at people holistically. People who come to us, maybe they have a psychosis, they have all these other issues as well. Sometimes they have to do with their health. Sometimes they have to do with their social connections. And we have to treat people and see them holistically and treat them holistically. And from a public policy standpoint, I'd like to see much more integrated funding that allows us to both in the research world do those more sophisticated studies that I was mentioning, but also when it comes to clinical the healthcare financing of services for people, because often we have singular funding that is for a mental health condition or a substance use condition, but not for both. And the people that we see need to have often that integrated care. And the more we silo people and we silo funding and we silo how we develop programs, the less effective we're going to be at treating the reality of people who come to us who often have multiple conditions.
Dr. Gordon, just to sum up your thoughts and what you want the audience to walk away with.
Well, I think we've talked a lot about the need for a holistic approach, which I also agree, and with studying the combinations of different approaches and making sure that we're bringing an evidence base to bear. And I think that's important. I would add as well, something that we haven't talked as much about, but was inherent in some of the earlier questions you asked, Ellen, which is that, comorbidities are there for a causal reason, and it can be important and helpful to try to understand those causal reasons. We heard about how dental disease can lead to mental illness and vice versa. Understanding those causal relationships can help develop interventions that can prevent that those causes from taking effect. And I think that's an important take-home message. For a lot of comorbidities that we haven't talked about, and even some that we have, we don't understand those causal relationships. And so the more we can learn about the structure of comorbidity and how it occurs, the greater the variety of interventions that we may be able to bring to bear on the problem.
Dr. Nguyen, what are your takeaways?
Yeah, I love the holistic approach, and that's exactly how I practice. And to do this, I think for obesity treatment, we need to take a biological, psychological, and behavioral approach, because without changing up here our way of thinking, we won't be able to change that behavior.
Dr. Ryan, what would you like audience members to walk away with?
Yeah, I agree with all of the other speakers, and I think this was a great session, by the way. I really enjoyed it myself. And I think that hopefully they will walk away understanding there is a connection between your mental health and your oral health. I think interdisciplinary care is essential to the best management of patients, but also in our research, right? And I think we need to work closely together when considering these comorbidities to really tease out these associations and to work to move forward the disciplines that we've been talking about here. So I think this has been really great.
I mean, I think it's so helpful to think that for a person, you can work on your sort of psychological well-being, but if you're embarrassed to be in front of people, you're not going to get better.
Yes.
No, it makes a lot of sense. Thank you all for your insightful contributions, and thank you especially members of the audience who contributed such good questions. It's been a real pleasure talking to you, and thank you for joining us. We're looking forward to our next and final session of today's programming, Building Trust in Health and Science with Effective Messaging and Messengers. So you can tune into that section in the lobby of the Zoom events platform. Thank you again to all of you, and I hope you enjoy the rest of the forum.
Thank you, Alan. Thank you.
Thank you, everyone.
Thank you.
Thank you.
Thank you.